Good afternoon. Welcome back, everyone, to WEDI's 2021 Summer Forum. This is Michael McNutt with WEDI. It's my pleasure to hand the microphone off to WEDI board member and member of WEDI's Administrative Automation Work Group, David Haugen from the Minnesota State Department of Health.
Thanks, Michael, and thanks everyone for joining us at today's WEDI Summer Forum session, Healthcare Automation at the Point of Care. As Michael mentioned, I'm Dave Haugen. I'm the session moderator and a WEDI board member, and on behalf of WEDI, would like to welcome you to today's session. I'm going to be providing some very brief background and context, and then we're going to be diving right in. So next slide, please, Michael. So you've probably heard the expression, data is the new oil, or if you haven't, you probably will be hearing it pretty frequently. That's a term that was actually coined by a British mathematician named Clive Humby way back in the dark old days of 2006. Based on all of the sessions that we've had this morning and the benefit of some of the previous speakers, we know that the world has changed and progressed pretty rapidly even since 2006. And when we think about data as the new oil, it's important to be remembering that, like oil, data needs to be refined into actionable knowledge to really be most useful. And not only refined, but that knowledge needs to be effectively, efficiently shared, communicated, and used. We know that parts of the healthcare system may have data. In fact, they may have a lot of it. And we know that parts of the healthcare system have refined that data into knowledge. But we also know that the needed data and knowledge are not often effectively or efficiently refined or shared or communicated and used as they could or should be. We know that the healthcare knowledge supply chain can be greatly improved. Next slide. So WEDI's been exploring this concept of a broken knowledge supply chain in healthcare for a while. Last year, for example, WEDI conducted a survey of the industry to really identify where this knowledge supply chain was weakest and most broken in terms of common healthcare business or administrative transactions. The results were clear. The weakest points, the weakest link in that chain from an administrative simplification standpoint, and as we've also heard from previous speakers this morning, was in the area of prior authorization and attachments. Next slide. So at our conference just a couple of months ago, we dug a little bit deeper into those pain points, those broken areas, and looked especially at prior authorization as kind of a microcosm or case study of this broken knowledge supply chain. And as part of that, we posed the question, what does a prior authorization nirvana look like? Next slide. And we imagined a world in which there was appropriate, comprehensive care for everyone, everywhere. We imagined a world in which knowledge flows for maximal positive impact with minimum burden and cost. We looked at wins for patients and providers and payers alike, kind of a healthcare trifecta, in which patients are aided and supported for optimal health, providers are aided and supported in providing quality, patient-centered care, and payers are aided and supported in really being fiscal stewards, supporting appropriate evidence-based care. But we know to get to that nirvana, there's some practical considerations. Transparency about when PAs are required and where the information is and how to get it. Easy access exchanges, tracking of required clinical documentation, and easy solutions to do all of this work that were within workflows at the point of care that are scalable and ubiquitous. Next slide, please. As you probably know from your own experience and from what we've been hearing already this morning, unfortunately, we're not at nirvana. Again, we know that there are pockets within the healthcare system that have the information and knowledge that's needed, but that supply chain for exchanging and using that information has been broken. We know that payer documentation requests and provider responses are often manual, and that creates bottlenecks and errors and unnecessary costs and burdens to everyone involved, as well as potential care delays and suboptimal outcomes for patients. So we know even in the best of times, this is a situation that needs improvement rapidly. But these have not been the easiest or the best of times. We're coming out of a once in a century pandemic. As we heard this morning, there's a great deal of development in standards and technologies that'll have very unsettling and hopefully promising impacts on the healthcare system. And we're also facing a number of future challenges with massive shifts in society and science, not the least of which is a rapidly aging population with a great deal of expanding health and social services needs. So next slide, please. So with that in mind, today we're offering 2 back-to-back sessions to offer some additional broader perspectives on a broken healthcare knowledge supply chain and the potential roles of automation to improve it. We'll be looking at both healthcare automation at the point of care, sort of the front office aspect or perspective in this particular session, followed by healthcare automation at the back of the office. Next slide. We're fortunate today to have perspectives from 4 presenters, and I think these will be very, very helpful, insightful, very interesting presentations that will be followed then with questions and discussion with our presenters. Of course, we're also encouraging you, the audience, to send us chat questions or some of your own ideas, and we'll try to incorporate those or follow those up as much as we can. But today, we're going to be hearing from our 4 presenters, starting with Todd Rago, President and CEO of HealthIX, followed by Jared Ulla, founder and CEO of HealthTalk AI, and then Dr. Kafir Ovid, Chief Strategy Officer of Navina AI, and then finally Jafur Traish, Chief Operating Officer of Aunt Bertha. And so with that, I think I'd like to turn it over to you now, Todd. And again, to everyone listening and attending, thank you for participating. We're really glad you're here and we're looking forward to a great session. So go ahead, Todd, and take it away.
Good. Thank you so much for the introduction. So pleasure to be here today. Thank you all for attending this session. I want to first start by telling you a little bit about the organization which I lead called HealthIX. We're a health information exchange. And you can kind of think of us as the plumbers of healthcare data within the ecosystem that we're describing here. So on the slide you're looking at here, our primary focus is New York City, Long Island. We do spread out across New York State and other areas as well, but primarily New York. And what we're showing you here is we're connected to 81 hospitals, other regulated entities, which is OREs, 731. So those are FQHCs, et cetera. We have a high number of physicians for whom's data we pull into the HIE. So over 27,000. That's a high number. Community-based organizations and behavioral health organizations, we have 159 of those. And then we are also connected to about 20 health plans. And these health plans, we bring in claims data as well as the clinical data from the provider side and really commingle this data set to get that holistic view of the patient. And then we also connect with IPAs, ACOs, and other types of organizations, including dentists, all of which have some sort of health information that we can help pull together around these unique residents of New York that we support. Let's go to the next slide here. So this is just a really high level. We have over 20 million patients that have had activity in the last 2 years. If you look at our full data set, which, as a company, I think we're 13 or 14 years old now, we're getting close to 50 million lives that we have data on. And you can imagine this is not only from the US, but because of New York being an international city, we have people from outside of the US, which end up in our healthcare systems in New York, and from which we get their healthcare records as well for those visits. But if you look at the upper right-hand corner, there are multiple HIEs throughout New York State. So downstate, you see HealthIX. There's a smaller one in the Bronx that's very specific to a portion of the Bronx. And then upstate, we still have 4 other HIEs. So this is, they each have kind of different territories of the state. New York State has a high population. It's a larger state. So this is what the landscape looks like right now. And in the bottom left, you see we're also connected to a lot of private HIEs. So as many of you are probably aware, whether you're a large IDN, a hospital system, or even some of the large payers, health plans, they're setting up their own private HIEs for which they use to exchange data within their 4 walls. So we take advantage of that as part of this kind of food chain. And we aggregate the data from a private HIE that represents a whole system or a large plan and bring that data into Healthix. So where there are efficiencies, we try to take advantage of those. And then we do a lot of collaboration down in the lower right-hand side with federal initiatives, being part of the SHEIC. I'm on the SHEIC board, which is the Association of HIEs. So very involved in national politics as well as state politics in terms of the policies that affect us directly as HIEs and affect our providers and health plan as a community that we work within. Let's go to the next slide here. So just a quick snapshot of the data that we move, just to give you a feeling of that. So we have to go through a lot of compliance training. So that's the 2,900 number down in the corner. But in terms of records that we push out, we have almost 8 million records that we actually push their clinical records into electronic health record systems that we interface with directly. So this is kind of on the back end, the wholesale side, where we push data into an Epic, an ECW, a Cerner, et cetera. And then we also have our own clinical viewer or clinical portal that we ask the clinicians to log into. So patient records, this is an average month. We have 8,600 patient records that are looked at by users that go out of their way to go into our portal. And then another major service we offer are really pushing out alerts that are triggered off from both types of encounters or a clinical condition. And we have a couple dozen of these types of alerts that are, again, clinically based or encounter based. And we push a lot of those out. The numbers have gone down since the COVID pandemic has subsided a little bit, but you can imagine during the testing, which is still going on in New York City, but the volumes of testing around COVID lab tests, we had a specific alert around that. And we were in the tens of millions every month when that was going back a year from now. So we push out a lot of data. We try to get it into the workflow of our users, and we try to be proactive as possible. Let's go to the next slide. So kind of setting the stage. So our role in the healthcare kind of food chain or supply chain that we were talking about earlier here is, again, we're the data movers. So we're the plumbers of healthcare. We like to think ourselves in that kind of role, kind of typically in the wholesale business. And what I mean by that is we move clinical information between healthcare organizations. It could be a payer or a provider organization. And we make, and in the retail side of our business, we also make clinical data available to patients or residents directly. So this is something very new, and we've been playing a much more active role as of April 5th, when the Cures Act kicked in from a federal perspective around giving patients the right to access their data through whoever they request it from. So it could be a health plan, it could be a provider, or it could be an HIE. And so we are empowered through policy, federal and state policy, to do this. So people can contact Healthix if you're a New York City resident and ask for your records. We also partner with a lot of EHR and a lot of apps that people are downloading on their smartphone these days. And we try to partner with a good technology partner to make that data available to them. So one case in point could be if you want to show that you've been vaccinated. We've partnered with one company to actually show that. There are many of them out there today, but we do share this information at the patient's request to help support their needs and actually to pull them in and be more involved in their healthcare. And you can see our Healthix mission here. So mobilizing health information across our communities to advance patient care. So really, we're moving the data, but our end goal is really to affect patient care. Our users, our customers are the organizations that access the data, but the end goal for us is really making sure the patient's data is used effectively in their care journey. So why now? Healthix, I think because of the pandemic, it's really kind of brought HIEs across the country more into focus in terms of the value. And one of those areas has been around public health. We activated many public health types of services in terms of locating loved ones in New York City who may have gone to a hospital without anyone else knowing in the family, just because of how quickly things hit. So there's a big public health component to what we do at Healthix. And I really feel we need a better community view and focus in healthcare data to really support us as patients and myself as a patient, right? When you think of Epic and they're connected to all of their customers, all their hospitals that are using their product, I think that's fabulous. I think that's great. But again, when you look at a community, let's pick on New York City, it's very diverse in terms of the types of electronic health record systems in place, the types of applications being used. And you really need an organization like an HIA to be that glue to kind of bring all this data together. I also think it's really important and become a major focus. Patients are becoming more knowledgeable and involved in their care, and we want to support that at Healthix. That's a big mission for us to support those activities. I don't think any organization should be competing over data. I think we should be competing over healthcare outcomes, and there are other areas to compete over as normal businesses, but this is one of our major goals. And then healthcare organizations, even if they have a private HIE or they're a very large IDN with over 100 hospitals, they only see the data that's within their four walls. So what Healthix brings to the table is that continuity of care from a data perspective that gives them that access to data which falls outside of their typical view as an organization. And we've done a lot of work to automate how we deliver this data in that respect. And then just really quick on the future state, I really think we need to empower the patient to become more involved in their treatments. And this is obviously a choice of the patient. We need to enable patients to share clinical records to care providers of their choice. So they shouldn't have to go and get a paper copy and carry files around with them. I think with the technology, which we certainly have in place within an HIE and outside of an HIE today, the technology exists to move records to follow patients wherever they go. So I think we need to further evolve in that area. And then support a community care team approach. This is when we talk about automation and how we leverage technology in these areas. I think this is one of the goals we have to think about. It's not just about the technology, it's about the approach, the process. How do we actually kind of move forward on these initiatives? And a community care team approach, I think, is really the best when it comes to caring for an individual, especially a complex individual in healthcare. And then turning clinical data into knowledge. So that's something that not just making it actionable or really focused in terms of our delivery, but turning it into knowledge that can be applied. So that's just really important. And let's go to the next slide here. So I'll bring you guys all into a few examples that we've delivered over the last few years. In New York State, to access someone's records, you need their consent. So if I'm the patient, Todd Rago, I have to tell my clinician, you have my permission to access my records. So the control is always in the patient's realm. And basically, we built something called the Flags API. It's not a fancy name, but it's meant to save the clinician time. So before they reach out to the HIE to pull the data in, they'll know right away if they've collected my consent as a patient. Otherwise, there's no point in reaching out. There's no point in clicking a button to go get additional data. And then the other thing we do is we tell them if there's new data available. So we don't just stop with, okay, now you can access the data. We want to tell you, since you've last looked at Todd Rago's record, is there new data available? So we try to automate all this on the back end, make it really easy for the clinician to understand, is there value in going out and looking for additional data? As we all know, time is very important, and there's not a lot of time when you're meeting with your doctor. So we want to save the clinician time to really prepare for that visit. And the other thing we've been doing here called Healthix Concise, we're really excited about this. This builds upon Firebase, APIs, so some of the newer technology that's available today. But we are actively pushing, so through an app, through Epic as an example, or through the Cerner store, we're able to bring in this widget right into their electronic medical record system, where it basically slides open a tray of information. So if you're in Todd Rago's record within the EHR, you can just move over a bar and it will just bring the relevant data into the record that you have at your organization, right in context. So you can look at my medications, you can look at my allergies, you can look at maybe a recent encounter, and specifically look up the discharge summary from a hospital across the street. And Is that Smart on Fire? It is. It's a Smart on Fire app. So we've been working with partners because, again, we're a small nonprofit. So in some cases, we build some of this technology and customize off from what we have, but in other cases, we work with partners. And this is one of those cases where we partnered with a great HIE out of the state of Maryland called CRISP. And we're using what they built as a product that's really fully integrated into a couple EHRs. And I'm excited because I mentioned the clinical portal before, but it's really hard to get a clinician to take the time, even if it's minutes, outside of their short amount of time with their patients to go look elsewhere. If they can get it all right there in an automated fashion in context, I think that's where the data needs to go and be made available. So that's at the point of care. And let's go to the next slide here. So some things we do to try to be proactive, and this is on the back office side of the equation, is there's a lot of querying and pushing of data that we do on the back end. So again, our role is around moving data, clinical data. So one thing we do is we have many large organizations that query us in advance of a patient visit. So whether that be an office visit in an outpatient setting or a planned hospital visit encounter, they will query us and we will give them a full clinical summary of that patient's record. And because of how things are shared in terms of the message standard that we use, a continuity of care document, a CCDA, they can break that data up and they can bring in the data that's relevant to why they're seeing that patient, Todd Rago. So they do a lot of querying in advance, typically the day before. So we've seen a lot more of this happening over the last several years. The second bullet here is us pushing out alerts. So that's being very proactive. They give us a subscription file of either members or patients that they know have certain clinical conditions that they really want to involve their care managers with. And we actively and proactively push out those alerts. And the alerts are really a small summary of clinical data saying, hey, Todd Rago's in the ER at Hospital A across the city, and you need to know because he's a diabetic patient. So these are, care triggered alerts, as well as encounter-based alerts, again, really geared towards the care management side of organizations. And then I'll just mention our analytics. We have predictive analytics, and we try to push out the predictive risk scores around who's trending in a negative health direction, right? So if I'm becoming a diabetic, but I'm not actually a diabetic, we're able to push out those patients that are moving in the wrong direction and notify the care managers in particular or the organization, hey, if you're caring for Todd Rago and it looks like he's becoming a diabetic, how can we proactively keep him from becoming a diabetic? And what we typically see is that organizations, if they have the person power to pull this off, they will call me in as a patient. They'll say, let's go over your plan again, maybe a care management plan. They may proactively recommend diet changes or lifestyle changes. And again, the social determinants of health in terms of data elements in healthcare has really become a more driving factor these days, and understanding, am I in stable housing? Do I have a stable, am I able to eat enough food? All of these affect people's healthcare. So it's all that data that we try to bring to the table and leverage in a proactive fashion. So these risk scores, and we even have some proactive predictive alerts that get triggered off from this. This is all based off from all sorts of clinical data and social determinants of health data that we use, again, in our ecosystem of healthcare. And let's go to the next slide here. One more slide. Okay, it's just my contact information. So that's available if people want to follow up. But hopefully I did the HIE Healthix some justice. We're in this small, but I think really empowered and powerful part of the healthcare, especially supply chain when it comes to data. People talk about data being the new oil. You talk about, how can we be more proactive? And I just want to say that as much as I'm about the technology and making data available, some of the struggles that we've kind of come up against are really about the process change and how can we make the data more consumable by our users, being in our case the clinicians, where they can take action off from it and really work it into their clinical processes, because that's really the challenge which we're feeling at Healthix is we have the technology, we have the data, we're moving it around. I think we're overwhelming some organizations with the volume of data. So we're trying to reduce the volume of data, make it more meaningful. But at the same time, we're finding that there needs to be some guidance and probably true investment in some organizations to actually have the person power to work it into their processes and actually to start to flip the equation of healthcare to be a little bit more proactive instead of reactionary. And that's it for my my summary up top. So David, I think it's back over to you, or back to our next speaker.
Thanks very much, Todd. This is Dave Haugen again. Really appreciated your overview. You had a few questions that came in. We will try and get back to those during the discussion period. And now we're turning it over to Jared Ulla, founder and CEO of Health Talk.
Great, thanks, David. Appreciate it. I'm going to share my screen here. That's okay. Can you guys see my screen okay?
Yes, we can.
Okay, great. Thanks for having me. It's really exciting. I think as we go into this, I think Todd hit on some key points around the plumbing, and we talk about automation in terms of leveraging data. It really starts with companies like Healthix, and so it's exciting to hear, what they're doing from data. Health Talk is really, if they're the plumbing, we're really the last 100 feet to the patient, and so. We, as nurse, we really got started in healthcare around understanding kind of where patients were. In terms of HCAHPS, patient experience is really where we cut our teeth. We're focused on really 3 problems for healthcare organizations. One, HCAHPS is not going away. Quality measures are not going away. The problem with that is as Todd mentioned, is a lot of that is not actionable information. It's not actionable data for provider organizations to actually understand how they're doing. If you think about it, it's kind of like quality metrics that are reportable, and HCAHPS is one of them. They're kind of the rearview mirror. And so really what they want is something that essentially gives them data that actually they can take action on. The third bucket is that it's specifically in the emergency room. We're live at 16, 17 health centers across the country, and in the emergency room, we talk about which patients, because of volume, which patients are actually going to have the gap is very difficult when you're in the moment because you're treating a patient, and so after they leave you, the providers have a difficult understanding in terms of which patients do I actually have to follow up with from a quality perspective, from a patient experience perspective. And so it's very difficult to identify gaps in care in real time. And then finally, everybody should, if there is an issue, you really need to kind of follow up with them. And following up in today's age is very difficult in terms of that. They don't have the manpower to actually call all 120,000 patients a year, like at some of these large level 1 trauma centers. And providers are frustrated because they want to do the follow-up, but they really can't. So if you think of in terms of automation, what we focused on at Health Talk is from a provider perspective, well, can we automate and can we look at each one of these buckets and can we actually automate the process of finding out which providers are performing well, which ones are not, which patients essentially will need that gap closure. And then finally, and I think the most important thing that we do is we close the loop. And so Health Talk AI really helps provider organizations engage all their patients. And I think in any language was really key for us. And so we identify that gap in care. We're going to be talking about patient experience specifically. But then what we do is we close the loop, and we close the loop with encounters. And so we use a bot technology that then facilitates contact between the provider and the patient when it's necessary. And so we won't get into the details, but that's kind of our secret sauce in terms of that. And so, yes, we use a text-based technology, but if you think about it, really in the future, talk about the future of automation, our bot technology could be used on a smart TV. It could be used on a voice-activated device. It really doesn't matter. We use texting, bidirectional texting, because that's what patients use. And so we're trying to meet the patient about that. So in terms of, if you think about in terms of meeting the patients where they are, we have to use what's in their pocket. And that happens to be a cell phone and texting at the moment. So how does it work really quickly? This is kind of the basic workflow of how it works. We engage the patient right after encounter. We can have an integration or a manual upload, doesn't matter to us. In our health centers, it's sometimes a manual upload because the quality directors want to have control over their care campaigns. But in any case, we immediately start engaging patients. It could be 500, it could be 5,000, depending on what the use case is. This one specifically is around patient experience. We identify which patients are having an issue, and we'll go into what that looks like from a patient perspective. When you think about the data, when the patient interacts with us in their language, we essentially then assess what that looks like from the care plan that's local at the healthcare facility. And so I think that's the real key to this, is that this is not cookie cutter. As a nurse, I learned a long time ago, healthcare is very local. We assess that data coming back from the patient in real time, and then we close the loop. And we can close the loop with telehealth using our telehealth capability or an e-visit, or even sometimes we're actually booking in-person visits. And of course, we have a dashboard and we have integration going back into the EMR. Those things are table stakes, which we won't really touch on right now. So what does it look like from the patient experience? It's interesting, the reason why I really started the company is because I've been part of health technology companies that we've developed apps, and quite frankly, the reason why we're failing as an organization, as a society, and as a industry is because it's very difficult. Talk about the barriers. So what we're trying to do at Health Talk is we're trying to reduce the barriers to engage. And so we don't have an app. You're talking the patient experience is what they have on their phone. And so we're using a bot technology to kind of engage the patient. So this is an example of what an engagement can look like, 100% configurable in any language. But this is pretty typical for our hospitals in terms of what we're trying to do. And you can see they're kind of broken down into 3 domains. It's kind of around, hey, how is your quality? Did you understand your discharge instructions? And if you didn't, we're going to do something about it. How did our facility, our operations meet your expectations? And then finally, in real time, this is what providers want. They want that real time information in terms of what patients are thinking about me. And then we kind of do that. The next thing we do is we scale that empathy in terms of patient engagement. Dr. Boise at Cleveland Clinic, I'm going to quote her. She talks about if we recognize an issue with patient experience, we should acknowledge it. And that's become a standard for us. And so every patient, regardless if they take a follow-up call or a follow-up visit with a provider, we're gonna apologize for that. So we're trying to scale the empathy here for the provider organization, automating that empathy, if you will, so that at least they know, hey, listen, we're sorry and we want to do something about it. And I think this is where, what we've also learned is that patients want to talk to their doctors. I'm a nurse, we do great work, but oftentimes, we can't write that script unless, we're a nurse practitioner, but we can't actually do something to actually do that. We can apologize, we can take that input. They want to talk to the doctors. And so we're connecting the doctor. In this case, what we're doing here is we're integrated with the physician's work calendar and or scheduling system, depending on what they want us to do. And so the bot here is actually automating, if you think about it, it's a virtual assistant and actually looking into, and you could have one provider, you could have 20 providers, it doesn't matter. We're going to look at the best option for that provider to connect with the patient. And essentially the patient can connect. We have a web application that you're looking at the right. We're not going to go too deep into that, but you talk about dashboard and data. This is what a web application looks like for providers. So we have an application for providers. Obviously, they need to know and track how they're doing in real time. Each provider kind of understands that and they can log in to see their data in real time. Or for patients, we just use a bot technology. I'm going to go quickly. So we have a couple case studies that I think are important. This is a large level 1 trauma center. We were live for over 2 years now here in Northern Virginia, DC area. They see about 120,000 patients a year. So what was the impact? They brought us in because we were live at one of our sister hospitals they are a level 1 trauma center. Like I said, they were having difficulties with HCAHPS, specifically in the provider area. They wanted to implement, because it's best practice to do callbacks, but when you have 120 physicians working and they're working in level 1 trauma center, very difficult, like I said, to actually do all those callbacks and make it patients to still pick up. So a lot of folks were frustrated. And so the clinicians were really falling off, because you had HCAHPS at 4 or 5 surgeries complete in 3 months. Very difficult to kind of move the needle in terms of behavior change. And so what do? They did a couple different things in terms of patient experience. At the bottom there, we actually bumped their HCAHPS scores by 49 points, or in the low 40s. They went up to the high 90s, and they're staying 2 years later in the high 80s. And so it's really about that feedback loop and providers talking to patients. We just happen to automate the interaction in between that. They weren't doing any callbacks before. Now they're doing about 70 a month that the system actually creates for them. They actually started during COVID telehealth, and so they're doing follow-up telehealth. I think the key thing in terms of clinical is, their telehealth, their 72-hour returns were about 6%, and that included COVID. When they implemented this automated telehealth capability, very similar to the workflow you just saw, they actually get that lower than 3%. So they're very happy. We're very excited to be a partner with Envision Physician Services. And finally, we talked a little bit about, other gaps. We are live at multiple health centers across the country, and it's the same technology in terms of this. But basically, what we're doing for health centers, and this is one of them, Upper Great Lakes Family Health Center, is we're becoming their communication and access point for all their patients. And so they brought us in during COVID, really because when they didn't have a virtual care platform, they wanted to communicate with all their patients. And really now they've really gone full bore with this and engaged the whole population in terms of that. And as you can see, they're not just working on patient experience, in terms of leveraging that quality metrics, but they're using the platform to identify other gaps in care, like A1Cs, Pap smears, and the like. And so super excited with them, super excited to be a partner with them in terms of that. So yes, automating that. Fast forward, we are a startup, being around 4 years. I'm envious of Todd. 20 million patients, congratulations on that. Helping New Yorkers for sure. We have 500,000 patients on our platform. Fast forward 4 years, we've almost sent and received 3 million messages, and we're continuing to drive those virtual encounters every day. So really excited about it. Really curious about questions. If there are any questions, we can take them at the end. Appreciate it.
Thanks very much, Jared. That was really helpful, and I really appreciate it. This is Dave Halligan again, the session moderator. We did have a couple of questions that come in, but we will take those at the end if we have time. We'd like to move forward now and continue with the presentations. Next with Dr. Kafir Ovid, Chief Strategy Officer of Navina, and welcome to the WEDI session. Thank you very much. I think you're muted, Dr. Ovid.
I am. Thank you very much.
Okay. There you go.
Thank you very much, David, both for the great introduction and also for the invitation to speak here. I'd like to speak today on behalf of Navina. I'm Chief Strategy Officer for Navina. And actually, Navina is around trying to take one of the most data-rich and knowledge-deprivated settings in the medical system, which is the outpatient clinic, and try to turn that into a place where physicians can benefit from the value of AI and from the value of deep learning. So when we're talking about outpatient physicians, they're largely overwhelmed by the amount and complexity of the data they have. So in the last few decades, the amount of data that was gathered in the outpatient is growing exponentially. But the tools to actually utilize this data and to extract some knowledge and wisdom out of it are largely absent. And the data has, to the best of our understanding or analysis, three main, I would say, gaps that needs to be bridged. The first one is that the data is not concise. So even if you have the data that you're looking for, It's buried under tons of other types of data, which are completely irrelevant, and therefore is not available to you and will not impact the workflow or the patient care. It's also not contextualized, which is really important. The patient is coming for a certain reason, but the data, I mean, is completely static. It's not dynamic, right? So data related and completely unrelated to this specific encounter is available to the physician, and there is no distinction between the two. The second gap is that a lot of the data, and again, Todd might also be testify for that, is completely unstructured. And for those of you that do not fully understand the meaning of the word unstructured, it's actually a fancy word for scanned documents and other types of formats where the data is not amenable for neither review nor utilization in an easy manner. And you'll be surprised, but about 70 to 80% of the data in the outpatient settings is actually unstructured. These are not tables or lab results. These are actually notes, consultations, all sorts of expert opinions and other types of data that are completely not amenable for reading, sometimes with wrong names, sometimes without any naming, completely inaccessible. And the third, probably the most important, physicians eventually have a very short encounter time with the patient. They do want to provide the best practice, but most of the data they have available is just not actionable. They don't really know what should be the next step with regards to their patient in light of all the data that is out there. Next slide, please. So this is the data gap is, in our eyes, not just a geeky nuance. Let's just structure the data or present the data. It's actually the result of that is actually some of the biggest challenges for the U.S. healthcare system, starting with the fact that, for example, physician cannot, for multiple reasons, provide preventive care, and we know that preventive care is at the basis of high quality and cost-effective medicine. The second is the ability to manage chronic diseases. So chronic diseases, both diagnosis of chronic diseases and mostly, of course, the management of chronic diseases is dependent on longitudinal data that is available, contextualized, collected, and analyzed in a way that a physician can make sense out of it. In the lack of such tools, with just a blurb of data, the ability to actually manage a chronic patient is, again, is significantly harder. And that obviously leads to loss of revenues of millions of dollars per physician group, but also for the entire system in the lack of efficacy for the workflow itself. Next slide, please. Now, just as an example, and people are talking here about diabetes, diabetes is not only a disease where you're trying to monitor or measure the level of glucose for a patient. Diabetes is a long-term disease with multiple different complications. And if a patient with diabetes is arriving to the physician, the provider will usually have to review quite a lot of data in order to understand what is the current status of the patient. For example, the physician will be interested to monitor retinopathy and eye problems, kidney problems, sexual dysfunction, ischemic heart disease, a risk, etc., etc. So these are all elements that for, I would say, a good practitioner will be necessary to manage this patient properly. But the problem is that the physician has only 2 minutes to do that, give and take, unless they take the time in advance to review the files, something they usually don't have the time to do. So next slide, please. So what I'd like to show you now is actually an alternative. And this alternative is actually, just a second, Michael, with 1 second with your permission. So before we see this 1-minute movie, I think this alternative is actually composed of 2 elements. The first one is a back-end AI-based data analysis and presentation tool that is allowing us actually to take this enormous amount of data that is available in the outpatient and in a physician-patient encounter-centric manner, actually to analyze it, to present it, and actually to allow the physician in a very easy way to get access to all the data and to make the right decision making at the right time, be available to the patient, and actually improve the outcomes, both the clinical and the economic ones. Michael, could you please run the video? Thank
We've
you.
all been there. Chaotic and disorganized patient data can lead to misdiagnoses, provider and patient frustration. Imagine the following scenario. Your next patient is a 63-year-old male who complains of weakness and fatigue. His medical history includes ischemic heart disease, diabetes, hyperlipidemia, atrial fibrillation, chronic kidney disease, COPD, and morbid obesity. To prep for the visit, you need to review his cardiology consult from 2 months ago, cardiac echocardiography report from last month, ED discharge from last month, nephrology consult from 3 months ago, pulmonology consult from last year, all recent labs, previous ECG, and current medications. That's a lot of valuable time you could have spent with your patients instead of your computer. Navina changes all that. It uses AI to give physicians a radically reinvented, contextually linked patient portrait. It highlights everything you need to know about your patient. Now, it's immediately clear. His GFR is deteriorating. His cardiac echo reveals mild, moderate diastolic dysfunction. And it looks like he isn't taking his COPD inhalations. No prescriptions were filled in the past year. 2 minutes for a comprehensive, in-depth pre-visit chart review.
Thank you very much. Going back to the presentation, so as you can see, basically what we're trying to do is to take the entirety of the data we have available at the outpatient to the physician. So the data is there, but again, the knowledge is not there, the context is not there, the availability is not there, and we're trying to contextualize the data to drive to action by detecting anomalies and other types of correlations within the data, and also to allow the physician to mine the data in a very easy, human approachable and intuitive manner, something that is not really accessible to physicians today because of the unstructured data of nature of the data. Next slide, please. Now, I'd like to show you in the last minute we have left to show you a case study from a multi-specialty independent ACO that we ran a study with, where we were trying to basically show that by engaging physician with such tools, we can improve both the value-based metrics and also the physician's burnout, so both economics and clinical outcomes, and also to do that in a manner that would be generalized. So for that we actually worked with 150 users in dozens of different practices, and importantly, the other stakeholders, which are critical stakeholders in the system, including nurse practitioners, MAs, physician's assistants, and care managers, were also part of the users that were assisting our system. Next slide, please. What we were able to show by actually making such a patient portrait available to the physician in real time at the encounter or minutes before is a pretty dramatic improvement in diagnosis, in treatment, in documentation, both of acute and chronic conditions, and which was immediately translated into both CPT and HCC rough score improvement. And just to name a few numbers, just to detail a few numbers, next slide, please. We were able to show a 33% increase in chronic disease diagnosis, something which was described in the literature. And we were very happy to see that the numbers in the literature were very similar to what we were able to improve. What's showing that such an approach might be able to close this amazing arbitrage of underdiagnosis. We're able to increase the rough score in about 38%, and that obviously immediately was translated into about $45K per physician per year in a net revenue, and we were able to increase the number of ICDs that were assigned per patient in 23% per visit. All these numbers are pretty staggering. Next slide, please. and a brief dive into these diagnoses. As you can see, and I won't go through the numbers and diagnosis, but the vast majority of them are chronic diagnoses. And again, what we see again and again is that there is an underdiagnosis of chronic conditions and undertreatment of chronic conditions, what is by definition providing, I would say, less favorable clinical outcomes, and obviously cost a lot of resources to the system due to delayed diagnosis, misdiagnosis, and more complications. So to conclude, we were basically building a physician-centric system that right now is taking available data sources, and in the future will utilize multiple other sources of data, including genome, including wearable devices, including other types of modalities where high quality data can be extracted and provide us insights about the patient, be able to analyze that and present that to the physician in context, in a concise manner, in a human approachable product that can allow them to do their job in the best possible manner. And by doing so, to obviously improve the clinical outcomes and the economic outcomes for the physicians group. Next slide, please. Thank you very much.
Thank you, Dr. Ovid. I really appreciate your presentation, and it was, again, very interesting and very helpful. We have a few questions that we will hopefully have some time for, but we're going to be moving on to our last presenter, Jaffer Trash, Chief Operating Officer of Aunt Bertha. And Jaffer, I will turn it over to you at this point.
Thank you so much, and I'll do my best to catch us up here. A little bit about Aunt Bertha. Our mission is to connect all people in need across the entire country to programs that serve them with dignity and ease. And these are social care programs, such as nonprofits across the entire nation. A quick glimpse into the nationwide network. Over 6.5 million people have already leveraged this network across the country. There's more than 500,000 nonprofit program locations across the country that are in the network that are helping people with things like food and housing and shelter, legal assistance, immigration resources, and more. And just over 77,000 of these program locations are actually leveraging the tools that we offer to them for free to support the people that they're caring for across the country. The top right shows a quick heat map of where people are looking for help across the nation. Before we dive into how we support some automation at the point of care, this just gives you a quick glimpse of what's taken place during the pandemic. We've added about 100 large enterprise healthcare organizations as customers just during the pandemic, and we've seen electronic referrals to social care nonprofits reach about 100,000 per month across the country. And so this is really very new in this nation to see this large number of individuals being referred to nonprofit organizations by folks not only in healthcare, but in government, corrections, education, and beyond. What's important to understand about the value of automating some of this process is that the needs are dynamic and they change rapidly, and they change rapidly at a local level. This is probably information never seen before, which is how did the social care needs evolve during the pandemic? And interestingly, of course, in March, after the pandemic began in this country at scale, food emergency went extremely high. Health services were put on hold. People stopped going to their clinic and other optional services. Financial needs rose. Housing steadily rose. So a lot of different trends that were happening that we need to be able to dynamically respond to faster than simply by assigning individuals case managers. That can take a longer time, and there aren't enough case managers to support all of the needs across the country. So a quick glimpse of what's happened across the country in terms of needs identification. This shows us the manual process of conducting assessments. This is where a case manager or another staff person is assessing an individual in this country and their social needs like food, housing, and others. And there are hundreds of thousands of people assessed, and that number is growing and growing by month. There's also ways that our customers have put personal assessments onto their own community-facing experiences, like LA Care, who serves 2 million people, and their social needs survey. So there's certainly a way for staff to conduct these particular assessments in a manual concept. And there's a way to begin to automate the process of notifying individuals who we think may be at higher risk for some of these issues based on their chronic diseases, based on the information they share about their veteran status or their income or other indications that are in the electronic health record or in their care management system or platform. And so we've already begun to use some automation technology to prompt individuals to begin to actually assess themselves. And we can take that a step further, not only by using kiosks that are available to people in waiting rooms, for example, some of the work we've done in New Jersey and in Philadelphia, but by automating the responses, the recommendations of programs that might serve an individual. So based on information that was put into the electronic health record or care platform or a personal assessment that someone completed, we can narrow down the specific resources that someone might be interested in. For example, in this case, we use data behind the scenes to recommend housing, health, and financial resources, given what we've learned about that person across many different data sources, of course, with their permission to give them these recommendations. And this can happen in many ways. This can happen through the network. This can happen through after visit summaries that are provided by EHRs. This can even happen through health information exchanges. I recognize HealthX on the line here, who has done a lot of great work with organizations along the social care needs spectrum. And so how we deliver these recommended resources can be transformed in this country as well, and we're beginning to see that. How do we take it a step further? How do we proactively reach out to individuals and automate some of those recommendations, especially for social needs? This is a quick example of something that we built with Microsoft, where based on the payer or the health system, if they've identified a cohort of individuals, perhaps it's a diabetic population, or perhaps it's a different population with housing needs, they can actually proactively use those cohorts to send those individuals messages in automated form, such as, do you need help with things like food or financial assistance? If yes, what's your 5-digit zip code? Do you need help with a specific type of service? Here are some specific local resources that we think you're eligible for based on the zip code we know that you live in. And so we're beginning this process of using more intelligence to recommend the best resources, knowing that someone's already eligible for them based on their zip code or income or other persona-based context details. We can also drive forward recommendations based on the domain of where that person's looking for help. And so we know that healthcare really cares about referrals for housing, food, and other care, whereas education and corrections and government typically help people with other needs like goods and services, transit, general services, and so forth. And so how can we support different industry, including healthcare, to automate the recommendations that are being shared with individuals? We've developed something called the Social Care Index, which maps and plots the availability of certain types of programs against CMS's Social Vulnerability Index. And this begins to tell us, are there good available programs near where some of the most vulnerable people are, and begin to marry that data with payer plan and other healthcare specific information about their population. So we can begin to create certain campaigns, whether they be vaccine outreach campaigns, whether they be food campaigns, or even spinning up what's been a popular trend lately, mobile dental clinics, so that we can actually get people back to the level of health that we all believe people deserve. And so again, lots of new interesting ways that we're beginning to use automation to help our customers and to help the general population get access to their social needs. I ran through it pretty quickly, but those are just a few examples of how we're using automation, and always happy to follow up with folks on the line. Thank you so much.
Thank you very much, Jafar. That was a very interesting, very helpful sort of capstone to our 4 presentations today, which again, I want to thank all of our presenters for. Looking at the clock, we're very close to the end of time, but we've been granted a few additional minutes. Michael, I just want to confirm we've had several individual questions specific to individual presentations. Will there be a way that we can grab those questions and forward those to our presenters?
That's correct, we will. In fact, on the Whova page, there is a community room called Speaker Questions, and we'll be throwing them on there, and we invite all the speakers to visit that, and we'll be sending it to them as well this week.
Great, thanks very much, Michael. So in the very, very short time we have remaining, just a couple of minutes, just a question for everyone. If you could think about a very short perspective or response. you have demonstrated some gaps and also some ways of addressing those gaps in the knowledge supply chain of healthcare. What do you think is needed to most rapidly continue to make improvements? And why do we need to do that now? And I'll open that up to all of you in whatever order you'd like to go. Whatever thoughts that you might have.
I'll just offer a very short and sweet comment, which is, I believe the more that we can support consumer-directed exchange of this information, where the consumer has the ability to know that, for example, I do want to share my referral history with Virtua because they also help me, or with my primary care physician, or I do want to control what my application that I'm using, then shares with a health information exchange. That consumer-directed privacy is going to build a lot more motivation for individuals to get involved in their care and in their information. And I think that's a theme that touches all of us.
Thanks very much. Any other thoughts? How do we start making changes even more rapidly? And how do we do that now? Any additional thoughts or perspectives?
Maybe a couple of words from our side. So our belief is that basically at the center of the medical doing, there is the outpatient medicine. The outpatient medicine, the community medicine is actually at the heart of everything. Still is, and probably will be in the next few decades, if not more. And one of the most deprivated places in the medical system that suffered from an increased amount of burden, without too many tools to assist to the physicians, is actually the outpatient. So we believe that in order to improve the outpatient medicine, to support value-based medicine, to improve the outcomes, and also to improve the economics of the entire chain of events, we believe that the tools that we're building needs to be much less back-end administrative, scheduling, billing, and other types of tools. And we need to touch upon this center of the medical doing, which is the patient-physician interaction. We need to support physicians in doing their job properly. We need to support them in coping with this tremendous amount of data that is being produced all the time. And we believe that these tools are not a magic. These tools will not replace physicians. These tools were meant to support physicians in doing better medicine, into doing more efficient medicine. And if we do that right, if we build these tools with the right technologies, but also in a human approachable manner, and also in a way that will fit the workflow and will not try to break the workflow, we believe we can make a lot of impact, both clinical one and also to improve the efficacies within the system.
Thank you very much, Michael. I'm assuming that, thank you again for giving us another couple of minutes. I'm assuming we're perhaps out of time. And so I would like to thank our panelists, Todd, Jared, Keffer, and Jafur. Thank you again very much for what I thought was a very helpful, very interesting, very informative, and very thought-provoking session. We really appreciate it. And
thank you for the opportunity.
Thank you.
And with that, Michael, I think we'll turn it back over to you.
Fantastic. Thank you, David. And for those who wish to continue with our summer forum, our leveraging automation at the back of the office will start momentarily. Please refer to your Whova agenda for the Zoom link.